Hello, everyone. My name is Jeff Hord, and on behalf of the ASFO Board of Trustees, I would like to welcome you to the 2021 ASFO Review Course. As past Education Committee Chair, I understand and appreciate the role that ASFO plays in providing continuing education through events like this. Whether you're attending this course to assist in your preparation for the American Board of Pediatrics certification exam, or attending to receive a comprehensive review of key concepts in the field, we hope you will find that this course meets and exceeds your needs. First, I would like to review some key points about our American Society of Pediatric Hematology Oncology. We are the only society that specifically addresses the needs of pediatric hematology oncology subspecialists. We have approximately 2,000 members and 200 active volunteers. The organization was founded in 1981, and our mission revolves around education, research, advocacy, and patient care. We're often known for our annual conference, but we provide other CME and maintenance of certification Part 2 opportunities. The Society's official journal is Pediatric Blood and Cancer. You might also know us through our website, our ASFO e-news, the clinical forum, webinars that we offer, lots of committee opportunities, and our working group. And of course, this review course. Why does ASFO offer a review course at all? Again, we believe we're a leader in education in this field of pediatric hematology oncology. This is an opportunity for us to expand the organization's role in training, education, and advocacy, and meeting our mission. This is a mechanism to provide CME credit to our members and other attendees. And of course, we want to assist our members in preparation for their initial ABP subboard certifying exam and help our members also in maintenance of certification. Our vision is clear and a compelling catalyst that serves as our focal point for our resources and efforts. And here you see our vision, which is to be the leading society for pediatric hematology oncology in a changing environment. This guides us in all that we do. Our core purpose is to serve our members in their quest to improve the health and well-being of children, adolescents, and young adults with blood disorders and cancer. I won't read through all of these activities and programs, but ASFO is guided by the strategic goals that help lead and prioritize our efforts as a society. Each of our 15 committees and task force fall under one of these pillars to accomplish our objectives tied to each goal. You can see listed activities here that fall under each area. I'll highlight the online member communities, which are free to join as members. There's a clinical forum open to all members. Each of our special interest groups, or SIGs, also has a forum for communication. And there's an early career forum as well. Two very popular mentoring programs are the speed mentoring session that we hold at our annual conference and our virtual mentoring match program. And I encourage you to learn more about both of these on our website. You can also see here some of the activities associated around workforce, some through our practice management committee. There's a web page resource. There's also a Choosing Wisely list. And then we conduct workforce compensation and training surveys as part of the work of that group. Here are some of the other major programs and services that we are involved with. And I'll highlight a couple. ASFO has been focusing on diversity, equity, and inclusion for many years and appointed a diversity advisory group in 2016 to help guide the Society's efforts. In addition, the special interest groups have become very popular among our members and provide a great opportunity to network with colleagues around a specific interest that you might have. They're free to join as a member, and I recommend that you look through the list of 15 on our website. ASFO is excited to bring you fresh perspectives on issues relevant to today's pediatric hematology oncology specialist in ASFOcast, which is our new podcast that was just recently introduced. Our first 6-part series is called The Road to Clinician Wellbeing, and it spotlights important topics such as the Stanford Well MD professional fulfillment medical model, physician burnout and mental health, mindfulness, grief, division and department culture, corporate wellness, work-life balance, and integration. You can find our podcast on your favorite podcast app or visit the ASFO website for more details. As I mentioned earlier, the Society is well known for its annual conference, and it is scheduled for April 20th through the 23rd. So please save this date. You will have the opportunity to attend virtually, and you'll have the opportunity to network with your subspecialty peers and earn CME right from your home or office. The meeting's virtual format promises abundant opportunities for such networking, and you can learn from expert speakers. You can engage in live Q&A with presenters, get real-time information, and connect with colleagues at numerous events. So please plan to attend ASFO 2021. If you have any questions regarding ASFO, please visit our website at www.asfo.org or contact our member services team using the contact information on the screen. Again, on behalf of the Board of Trustees, we certainly hope that you find this review course a valuable experience, and we wish you the best of luck in your educational endeavors.
Welcome everyone to the 2021 Pediatric Hematology ASFO Board Review Course. I'm Paul Harker Murray, one of the review course chairs, and I'm working today with Cindy Noonert, the review course vice chair. I want to say a special thank you to all of the planning committee, the ASCO Education Committee, and all of the people who have volunteered their time to give talks in this course. The 2021 ASFO review course has the following goals: to provide a comprehensive overview of pediatric hematology and oncology, to assist attendees with preparation for their certifying exams, maintenance of certification, CME credits, and some of you are even here for a general update. We also offer a virtual course, all of which will be available on demand for the next 2 years. Invited speakers are members from ASFO, as well as national and international experts in their field. In terms of the speakers and presentations, there are 31 sessions providing a broad overview of the subject areas, some presented as part of the live course, and others are presented as part of the on-demand course. All registered attendees have exclusive access to all of the on-demand sessions after the course, and you can access them through this virtual platform, as well as through the ASFO My Library after the course. There will be extensive coverage of topics listed in the current ABP content outline. This was released August 1st, 2018. There will be a virtual networking reception, and please refer to the emailed instructions and attendee guide for more information on the virtual platform. This is the content format as suggested by the ABP. We no longer have a list of know this, know this, know this questions that became fairly archaic. Instead, this allows us to give the kind of talk that we want, talking about the basic science and physiology, the epidemiology and risk assessment, the diagnosis, management, and treatment. All of the speakers have been asked to organize their talks according to this format. So you will see this slide multiple times throughout the course. The Pediatric HEMONC Subboard Certifying Exam has the following 11 content domains. And on the right, it shows roughly what the percentage breakdown is for each of those. This is a reminder that although we work closely with the ABP, we do not have access to any of the test material, but rather we have internationally and nationally recognized experts designing talks to broaden as much knowledge as we can.
So we changed platforms this year because of COVID, and we have a new virtual platform. We also have some other new additions. We have 8 new speakers. We have new and improved multiple choice questions and explanations. Each of you will receive 100 practice questions, which are available on the virtual platform and in your ASFO My Library. But you also all have the opportunity to purchase the full complete guide with 500 plus multiple choice questions. We're going to use a consistent format, as was mentioned, for all the presentations based on ABP content outline. And you will, again, have access to all these sessions on demand. There's also a digital syllabus that's available as a PDF in color, and this is also available through the platform and your MyASFO library. So we just want to highlight there are some discounts since you're attending the meeting on the supplemental study materials, which include a full printed color syllabus, which we have some limited quantities available if you want to reach out to ASFO. We also have, as mentioned, the self-assessment question book. And for either of these, here's the information for how to get in touch with ASFO to request these supplemental study materials. As always, we want to remind you that your evaluation is critical. And as a bonus, it also will give you some CME credits. But it helps us with the overall course content. It gives us some details of how we should format the course, as well as review of individual speakers. And then also it allows you a chance to review the questions. And we really value this in terms of how much did this help you prepare for the exam, and are we achieving the goals that were outlined in our very first slide. For each of these, there's going to be a graduation cap icon on the ASFO review course in the My Library that you click on, and that will guide you to complete the course evaluation. But also stay tuned for more instructions towards the end of the meeting. So during the sessions throughout the scheduled week, we want to encourage use of the chat and the Q&A feature within the platform. If you use the chat and the Q&A throughout the session, it helps us keep track of the incoming questions and discussions so that we can then prioritize them. And if you see a question submitted by somebody else that you think is really important, just click on it and that will highlight the importance and move it up in the query so that that question will then go to the front of the line for being answered. And also ASFO staff will be communicating with us through the chat for announcements during the session. So please keep an eye out for those as they come in. We have a virtual networking and mentor session this afternoon at 3:30 to 4 Central Time. We will be giving away $200 Amazon gift cards to some random participants. So that's exciting. And these were really designed to be a mentor breakout table to use this opportunity to help you engage with not only expertise within the field, but also with ASFO leadership. So these breakout groups consist of former and current ASFO leadership, as well as some of the speakers from this meeting. So great opportunity to network with each other and also learn more about how to become engaged with ASFO as an organization. We will also be offering virtual office hours. These will be numerous 30-minute Zoom meetings that will be organized by speaker and topic for question and answer sessions. These will be held late February to early mid-March, and details will be forthcoming. So please watch for email announcements with regards to upcoming office hours. We do have one minor schedule change highlighted here, and that is just that the 2:15 to 2:30 break on January 29th was left out of the schedule. So please just make note of that if you are working with a printed syllabus. So for any questions, you can reach out to technical support, ASFO support, as well as Dr. Harker Murray and myself. We're really excited to have you joining us, and we hope that this meets all of your needs and makes you well prepared for the exam. Thank you.
Thank you.
Good morning, everyone. My name is Kathleen Cook, and I will be moderating today's session, Brain Tumors, presented by Dr. Fangasaro from Emory University and Children's Healthcare of Atlanta. A few announcements before we get started. Be sure to use Google Chrome as your web browser for the best experience. Don't forget to network with colleagues in the chat box at the bottom and utilize the Q&A feature to ask the speaker questions. If you see other questions that you would like to see answered, you can click the vote the question to raise the question up on the priority list. Following the lecture, there will be a dedicated Q&A time at the end of the presentation. If you experience any issues viewing the session, please try refreshing your screen or visit the support tab at the top of the screen. To get our chat started for today's session, please state where you are from. Now I will turn it over to Dr. Fangasaro.
Hello, everyone, and welcome to the ASFO Board Review course. My name is Jason Fangasaro, and I am going to be giving you a review of brain tumors. If you are watching this at the actual course, good morning. And if you are reviewing this at 2 in the morning, the night before your board exam, May the force be with you. Okay, let's move on. So the way I'm going to organize this talk is kind of based on what the American Board of Pediatrics is recommending. So there are some universal tasks that they ask us to review, and those include basic science and pathophysiology, epidemiology and risk assessment, diagnosis, and then management and treatment. And if we look specifically at the solid tumors, they ask that we look at clinical presentation, diagnostic imaging, pathology, and then any other specific relevant laboratory tests. And then there are very specific brain tumors that they ask that we highlight. And those include medulloblastoma, low-grade glioma, high-grade glioma, ependymoma, central nervous system germ cell tumors, and then quote unquote rare brain tumors. And then finally, they would like us to review some late effects of brain tumor and brain tumor therapy. So my goals today are really to discuss the general CNS tumor epidemiology and etiology with you. We will do a quick neuroanatomy lesson just to all get our bearings in the brain and spine. And then we'll discuss the specific brain tumors that I mentioned on the previous slide. And when we talk about each of them, we will review epidemiology and risk assessment, diagnosis, pathophysiology and biology, management and treatment, outcomes, and then late effects. And then my own 2 personal goals is really to make sure you get the 4 or 5 brain tumor questions on the board exam correct. I'm hoping that these are give me questions after you listen to my talk. And then I really want you all to recognize that pediatric neuro-oncology is clearly the most exciting subspecialty. Okay, let's get going. So one last important point, red font. Red font is my way of highlighting key points throughout the presentation that I really think are, 1, important to remember or just strictly memorize, or key concepts that make for good test questions. So be on the alert out for the red font, and when you're studying, these are areas to focus on. So we're going to start with a general overview of pediatric CNS tumors. So CNS tumors are the most common solid tumor malignancy in children, and they are the 2nd most common malignancy seen overall, as you know, after leukemia. Okay, here's some of that red font to keep an eye on. Astrocytomas are the most common brain tumor overall, and these are most commonly low-grade tumors, and we'll discuss that more as we move forward. And then medulloblastomas are the most common quote unquote malignant brain tumors. Now, I personally hate the terms malignant and benign, and I won't get on my soapbox for you, but for the purposes of this exam, medulloblastoma is the most common malignant brain tumor. Also, the incidence rate in males is much higher than in females. If you look at all brain tumors overall, it's about 1.2 to 1, but it's higher in specific brain tumors, which I will mention later. There's about 3,000 to 4,000 brain tumor cases in children every year. And if you look at the overall survival, it's about 70 to 75% at 5 years. This, however, is quite misleading because, as you know, there are specific brain tumors with very poor prognosis and very poor survival. And of course, overall survival does not represent the significant morbidity and late effects that many of our patients live with throughout their entire life. So, another really key important point is that adult brain tumors and pediatric brain tumors are very distinct. They are unique histologically, biologically, and the treatment paradigms and the outcomes are very different. So I don't want you to memorize this pie chart at all, but the reason I put it on here is to show you that pediatric brain tumors, there are numerous histologies. You can see all the different colors among this pie chart. If this were a pie chart for adult brain tumors, there would be 1 or 2 or maybe 3 sections, mostly glioblastoma multiforme or high-grade glioma, maybe some ependymoma, and a few other rare tumors. But the point of this slide is that pediatric brain tumors are very distinct from adults, and they should not be considered the same when you look at biology, histology, or even treatment paradigms. So what causes pediatric brain tumors? Far and away, we do not know what causes pediatric brain tumors, but there are 2 things that can lead to pediatric brain tumors. And because of this, they're easily testable. So you can see they're in red font. So a history of ionizing radiation can lead to a secondary malignancy. So for example, in the era when patients with CNS leukemia received radiation, some of those patients were at risk later in life, often 7 to 10 years later, for developing a secondary brain tumor or a high-grade glioma. That's easily testable. Also, there are genetic brain tumor predisposition syndromes. Now, these are very rare, but again, they are easily testable, and we'll look at these on the next slide. So this table goes over the most common genetic predisposition syndromes for brain tumors. I am not going to review this in detail right now, but I am going to highlight the entire table in red because this is something that is easily testable. We will also highlight some of these as we go through the specific brain tumors, but this is something I would spend some time on during your studying. Okay, let's talk about our basic neuroanatomy of the brain. On the left side of your screen, you can see the different lobes of the brain. And we'll talk on the next slide, the functioning of each of these lobes. But we have our frontal lobe, our parietal lobe, our occipital lobe, our cerebellum, and then the limbic lobe, which is less important for the confines of this talk. And then if you look on the right, you can see the specific parts of the brain. So the cerebrum, the choroid plexus, which produces our CSF, the pineal gland, the pituitary gland, which has a lot of our hormone regulation, the brainstem, including the pons and the medulla, and then the ventricles, which are the spaces of the brains where the cerebrospinal fluid is flowing through. Now, the majority of brain tumors in children are in this infratentorial region. That red line is an artificial tentorial line, and most of the patients that we see in pediatrics will have brain tumors below that, so most commonly in the cerebellum. However, there are about a third of patients that will have brain tumors in the supratentorial region. So this is something that we see in pediatrics. So this is the localization of symptoms based on the anatomy. Again, I'm not going to go over each of these, but just to highlight a few. For example, a seizure focus is often seen in the temporal lobe. So if you have a tumor in the temporal lobe, these patients may present with seizures. The occipital lobe is very important for our vision. And so patients that have occipital lobe lesions may have vision dysfunction. And then, for example, the brainstem, you may see cranial neuropathies, such as swallowing dysfunction or a lateral rectus dysfunction with eye movement abnormalities. Another way to break down symptoms for brain tumors is to look at them versus localizing symptoms and non-localizing symptoms. So patients that simply have a burden of a tumor in their brain can get these generalized non-localizing symptoms. And these can be things like developmental delay, decline in school performance, or behavioral changes. And then patients can also develop obstructive hydrocephalus because of a tumor, blocking the flow of CSF. These are the classic symptoms that we think of when we think of brain tumors, like headaches, vomiting, lethargy, papilledema. Then we can have localizing symptoms. Those are the ones that we discussed on this previous slide with the different anatomy of the brain. And so, for example, if you have a tumor in the right motor cortex, you may develop left-sided weakness. And then a final one that we'd like to highlight are endocrine symptoms. So for example, patients who have tumors in their pituitary region may develop endocrine symptoms like diabetes insipidus. And these can sometimes go along with specific histologies that we'll talk about, like craniopharyngioma or CNS germ cell tumors, for example. Okay, so here's a fun game you can play at 2 in the morning when you're trying to test yourself. Again, I won't go through this right now, but something simple to test tumor location versus symptom. I don't think they're going to test you specifically on this, but they may include them in a question which will help guide you and understand the best way to move or answer the question. And so you can see the right answers as they color here. Okay, so let's dive into the specific types of tumors now. So the first one we'll talk about is the low-grade glioma. Low-grade gliomas are the most common brain tumor that we see in children. This is a very broad term, which includes World Health Organization grade 1 and 2 glial or astrocytic tumors. There are numerous histologies. Pilocytic astrocytoma is the most common histology, but you can get other tumors like ganglioglioma or diffuse fibrillary astrocytoma. But in general, we lump these all together in one box and they are evaluated and often treated the same. So here's a pie chart. We're going to come back to this pie chart numerous times throughout the talk, but you can see that purplish color includes astrocytoma and glioma. And remember, astrocytoma is the most common brain tumor that we see. But here it represents both high and low-grade tumors. If we break it down to just low-grade tumors, it represents about 40 to 50% of all brain tumors that we see in children. So this is very frequently seen in a neuro-oncology clinic because it's the most common tumor that we see. So a few risks that lead to low-grade tumors. And again, these are easily testable. So there's something called a subependymal giant cell astrocytoma, or a SAGA, and this is associated with a diagnosis called tuberous sclerosis. It's historically treated with surgery, but we understand that the mTOR pathway is key in this propagation, and now mTOR inhibitors are typically frontline therapy. That's something that you probably should remember. Also, there is an increased risk of low-grade glioma in children who have neurofibromatosis type 1. And you can see the diagnostic criteria for the NF1 there, which also includes optic pathway glioma. I have a specific slide on NF1 because I think this, again, is something that's easily testable. About 15 to 20% of patients with NF1 will develop low-grade gliomas in their brain, most commonly in the optic pathway, though they can occur in other locations like the brainstem. These can often be asymptomatic and indolent, and interestingly, they do not always require treatment. So we may recognize that a patient with NF1 has an optic pathway tumor, but if their vision is intact and they are not having neurologic symptoms, we will not treat them. And in fact, we only typically treat these patients if they have one of those functional deficits or neurologic symptoms. If we do need to treat these patients, they are typically treated with chemotherapy first. And that chemotherapy is most commonly a combination of carboplatin and vincristine or vinblastine monotherapy. Now, this is a key point and very important. We avoid radiotherapy and alkylating agents in patients with NF1, and this is because they have a high risk of secondary malignancy. So I would never choose radiotherapy as an answer of treatment in a child who has NF1 on an exam for sure, and actually in practice as well. So here's an example of a patient with NF1 and low-grade glioma, two examples, in fact. And if you remember, in an MRI like this, on an axial view, the right side is the left side and the left side is the right side. You can see the eyes pointing upward. And on the left side of your screen, you can see a patient with a right optic pathway glioma that enhances when contrast is given. And then on the right, you can see a 3-year-old with NF1 and bilateral optic gliomas. Here, they are just more tortuous, and there's not actually a definitive mass. And oftentimes, this is what we see on imaging. Remember, we would only treat these patients if they had functional deficits like visual decline or other neurologic problems caused by the tumors. So if we look at low-grade gliomas in general, the diagnosis is made by biopsy with the goal of total resection whenever possible, the exception being NF1 patients, which we already discussed. These tumors in general, low-grade gliomas, do not spread to other parts of the brain and spine, so a full staging workup is not typically needed, but you may need to do a spine MRI in specific situations. For example, if a patient presents with back pain and they have a low-grade glioma in their brain, a spine MRI may be warranted. Or if a patient has a unique histology that we know has a predilection to spread to the spine, we may consider a spine MRI. So for example, there's a diagnosis called pilomyxoid astrocytoma that often metastasizes. And in those patients, many practitioners will get a baseline spine MRI. Lumbar puncture for CSF cytology is not routinely performed or required for staging in these patients. That's different than some of the other diagnoses that we will discuss. In terms of pathology, the most common pathology, as I mentioned, is called pilocytic astrocytoma. It is characterized by low to moderate cellularity. It's GFAP positive, and there are often dense fibrillary areas. It is characterized by something called Rosenthal fibers. These are astrocytic cytoplasmic inclusions that are typically elongated or corkscrew, and they are pink or eosinophilic on H&E staining. These can occur in many pathologic conditions, but for the purposes of the board exams, if they include the term Rosenthal fibers in a brain tumor presentation, the answer will be pilocytic astrocytoma. Okay, we have learned a significant amount about the molecular biology of low-grade gliomas over the last decade. We understand now that aberrations of the MAP kinase and mTOR pathway are the most common abnormalities that lead to propagation in these tumors. And here's a simple representation of the MAP kinase pathway. You can see the association of NF1 on the left, and then the characters involved in the pathway, BRAF, MEK, ERK, and when you have propagation down this pathway, of course, you lead to transcription and proliferation. And we're gonna focus in on BRAF because we understand a little bit more about specific abnormalities in BRAF in low-grade glioma. So the most common mechanism of BRAF activation in low-grade glioma is a genetic fusion resulting in the loss of the regulatory domain of BRAF. It's called a KIA 1549 fusion, and it's been described in the majority, up to 80% of pilocytic astrocytomas, and some people feel even more if evaluated properly. Also, there is another mechanism of BRAF activation called a V600E mutation. This is something that is often seen in melanoma, for example, and in a lesser extent, it can be seen in low-grade gliomas, about 10 to 15% of pilocytic astrocytomas, and seen in other low-grade gliomas like pleomorphic xanthoastrocytoma and ganglioglioma. And interestingly enough, rarely it can also be seen in high-grade glioma in pediatrics and adults. In terms of management and treatment, if possible, you should try to get a low-grade glioma gross total resection from a neurosurgeon. If there is a gross total resection, these patients can be observed and they often have very good outcomes. If there is residual disease or tumor is unresectable, chemotherapy is and again, the chemotherapies used are two that I mentioned previously, carboplatin and vincristine, or vinblastine alone. There's also a third that can be used called thioguanine, procarbazine, CCNU, and vincristine. That's known as TPCV. This is one you would not use in patients with NF1 typically because of the inclusion of alkylating agents. Now, radiation is a very effective strategy at treating low-grade glioma. However, we typically avoid it in our patients because they are young children and there are a lot of late effects of radiation therapy, including neurocognitive decline, endocrine dysfunction, ototoxicity, and secondary malignancy. So this would not be the first choice in most patients with low-grade glioma. Remember, in NF1 patients, you're going to avoid both the alkylating agents and radiation therapy. And then now, based on our understanding of the molecular landscape, we have begun testing molecularly targeted agents such as MEK inhibitors and BRAF inhibitors, and they are in clinical trials. I doubt they would test you on these specific agents because the phase 2 agents have only recently been published in recurrent population, and now a COG study is recently opened in both NF1 patients and non-NF1 patients testing these agents compared to classic chemotherapy. However, these trials are just accruing patients and there is no data on the results yet. The outcomes for patients with low-grade glioma is overall very good if you look at overall survival at 5 years with the gross total resection close to 90 to 95%. In the patients that don't have a gross total resection and need chemotherapy, the most recently published data from the CCG or COG A9952, this was a study comparing the carboplatin vincristine regimen to the TPC regimen. And when we looked at all patients, regardless of what they received, you can see the 5-year overall survival is very good, close to 90%. But we have this 5-year event-free survival at 45%. And so you can see there's a lot of patients who recur and require alternative therapy throughout their childhood. I have one slide on this entity called diencephalic syndrome, just because I think it's easily testable. It's a rare condition caused by a tumor in the hypothalamus or the diencephalon near the hypothalamic and thalamic region. It's usually seen in infants and toddlers, and it results in a constellation of symptoms, typically failure to thrive, abnormal eye movements, and later on, vomiting and hydrocephalus. It's often caused by a low-grade glioma, and when you do a biopsy, it's often a pilocytic astrocytoma. We don't understand the mechanism of this or the endocrine reason that patients develop these symptoms, but once they are treated with low-grade glioma chemotherapy, they typically improve and they start gaining weight. But this is something that you may see on a test question. Here's an example of a classic case and a test question that you can read on your own later. And this is an example on the right of an MRI showing a large enhancing mass in the hypothalamic region. This was actually one of my patients, and it was a pilocytic astrocytoma. And this patient did present with failure to thrive. Okay, now we're going to move on to the sister, quote unquote, of low-grade glioma in that astrocytic group, the high-grade gliomas. Now, high-grade gliomas are very aggressive and malignant tumors. The World Health Organization classifies them as grade 3 or grade 4 tumors. You would think of GBM or glioblastoma multiforme. Many famous people, unfortunately, have had this diagnosis, like Senator Ted Kennedy, for example. This is much more common in adults. Again, the biology is very distinct between children and adults, even though the histology looks similar. And although it is less common in pediatrics, we do see high-grade glioma in patients who are younger. However, it's much less common than the low-grade gliomas that we just discussed. And high-grade gliomas are much more resistant to therapy and have a worse survival. We come back to our pie chart here. And again, that purple color is all astrocytomas, low and high grade. And if we break it down into the high grade, it's about 10 to 15% of all pediatric brain tumors. Now, in terms of risk, there is an increased risk in patients with previous exposure to radiation therapy, which we've discussed previously. And then there is an increased risk in patients with Lee-Fraumeni syndrome or TP53 gene mutation and familial adenomatous polyposis, say that 3 times fast, because those patients have an APC gene abnormality. Both of those diagnoses have an increased risk of high-grade glioma. And again, that's easily testable. So if we look at diagnosis and evaluation, you do need tissue or resection to see pathology on these patients. The one exception is the diagnosis of diffuse intrinsic pontine glioma, and we will have a specific slide on that to discuss that separately. But for high-grade glioma in general, the goal is to resect as much of the tumor as you can. This is often difficult for a couple reasons. One, because it may be in a midline location that is hard to resect, or two, the patient's tumor is often very infiltrative. They have these finger-like projections, and for a neurosurgeon to continue to cut until they got a clean margin would cause significant morbidity because they would continue to be cutting at normal brain tissue. Now, although these tumors rarely spread to other parts of the brain and spine, it is considered more standard in this group to get a baseline spine MRI, and that's what most practitioners would do. However, again, like low-grade gliomas, a lumbar puncture for CSF cytology is not routinely performed for staging. For pathology, these patients classically have pathology characterized by a high cellularity with numerous mitoses. They will have vascular proliferation and something called pseudopalisading necrosis. And they're usually GFAP positive, but this can be negative in some high-grade gliomas. Now, pseudopalisading necrosis is when a rapidly proliferating tumor cells are stacked or palisade around a central pale area, which is represented not necrotic tissue. And basically what's happening is the tumor is growing so fast that it's outgrowing its own blood supply. And this is a very ominous finding. I do not believe that they're going to give you a picture of this on the exam, but I think if they gave you a description of pathology with these features in red, highly cellular, high mitotic activity, vascular proliferation, pseudopalisading necrosis, they're trying to get you to identify glioblastoma multiforme that has a very poor prognosis. Now, this is a slide on that specific diagnosis, diffuse intrinsic pontine glioma, DIPG. These are diffusely infiltrative high-grade lesions of the pons. So you can see on the right, this picture, which I think they could potentially put on the exam. You have engorgement of the pons, and this picture in itself is diagnostic. They typically do not enhance that diagnosis, though this can vary. They represent about 10 to 12% of all pediatric brain tumors. They can be diagnosed by imaging alone, although more and more people are doing biopsy to look at the biology of these tumors. The classic age is about 5 to 7 years old. And when you do a biopsy, about 80% or more of these patients will have a histone mutation called H3K27M. We'll talk a little bit more about that on the next slide. A complete resection is not feasible and should not be performed. And patients typically present with a very short duration of symptoms and a classic triad of symptoms. They'll have cranial nerve symptoms like swallowing dysfunction or eye movement disorders like lateral rectus palsy, for example. They'll have long tract signs like hyperreflexia, and they may be off balance or have ataxic gaits. The only known effective therapy is focal radiotherapy, which only is effective for a short period of time. And most patients will recur and progress and succumb to the disease within 10 to 12 months from diagnosis, regardless of the therapy. So let's talk a little bit about the molecular biology of high-grade glioma. I mentioned this molecular feature H3K27M mutant. This is a histone mutation that now characterizes something that is a new entity recognized by the World Health Organization. If you have a midline tumor and has the H3K27M mutation, it is called a diffuse midline glioma H3K27M mutant. These are highly infiltrative lesions. and they are considered grade 4 lesions of the midline. So most commonly, they would be seen in the pons, like the DIPG that we saw on the previous slide, or they can be seen in other midline locations like the thalamus, for example, or the spinal cord. If you look at DIPG, the ones that have been biopsied, over 80% of them or more will have this classic molecular abnormality. There is a less common histone mutation seen in other high-grade gliomas, H3.3G34R. I do not think you will be tested on it, but I included a small sentence on it here. In terms of treatment, the best known therapy for high-grade glioma is to get as much of the tumor out as you can, and then combine focal radiotherapy with chemotherapy. Now, historic studies have shown that chemotherapy plus radiation therapy is better than radiation therapy alone, but this data is a bit controversial and there are a lot of confounding factors. So it's not really agreed upon universally what chemotherapy should be used. And so most of these patients are often treated in the confines of a clinical trial pairing radiotherapy with a novel agent. The exception are infants, most commonly less than 3, but it's probably not really the age barrier, it's more the biology of the tumor. And these patients seem to have a more indolent course and a unique biology, as I mentioned. They can be treated with chemotherapy alone approaches, and radiation can be avoided or sometimes delayed. The outcomes are universally poor for these patients. 5-year overall survival is about 15 to 20%. And again, as I mentioned previously, because they have unique biology, infants probably have a slightly better outcome. Okay, we are going to move away from the astrocytic and glial tumors and move on to medulloblastoma. So medulloblastoma, as I mentioned before, is the most common quote-unquote malignant brain tumor of childhood. It's a highly aggressive and rapidly growing embryonal tumor because it does look like embryonal tissue under the microscope. And it is located in the posterior fossa or the cerebellum by definition. This has changed over time, but currently for you to call something a medulloblastoma, it must be located in the cerebellum. Now we are back to our famous pie chart here, and you can see medulloblastoma in the green, representing the most common malignant brain tumor, about 15 to 20% of all pediatric brain tumors. And the ratio here is a bit higher in males compared to females, even compared to all brain tumors overall. So close to 2 to 1 in medulloblastoma, males having more of it than females. The risk of this tumor is a few things that we should keep in mind. There is a risk in a diagnosis called Gorlin syndrome, also known as nevoid basal cell carcinoma syndrome. Again, this is on that chart I showed you at the very beginning. This is due to a patch gene mutation. And then an increased risk in familial adenomatous polyposis, like Gardner's, and Turcot syndrome, again, due to that APC gene mutation. So again, easily testable. So I would keep this in your mind or memorize for a short period of time. Diagnosis, it's typically, if you look at imaging, you're going to see a large heterogeneous mass. Again, has to be in the cerebellum, oftentimes has contrast enhancement. Your goal is to get as much of the tumor out as possible, as this is prognostic, which we'll talk about in a little bit. And then about 30% of cases will have metastasis to other parts of the brain and the spine. So it is important that you do both a lumbar CSF cytology and a spine MRI as part of staging. This is a little different than the previous 2 diagnoses that we talked about. Also, for a spine MRI, it should be done before a surgery or 10 to 14 days after a surgery to avoid post-surgical blood products confounding your evaluation. Also, a lumbar CSF cytology is typically done 10 to 14 days after a surgery, again, to avoid that post-surgical confounding blood products. Lumbar CSF is typically not done pre-surgically because at that point, most patients have obstructive hydrocephalus, and that would be dangerous, leading to possible herniation. So it's typically done after a surgery. Here's a classic image of a patient with medulloblastoma. As you can see, a large mass in the posterior fossa near the 4th ventricle. And on the right, you can see it has some contrast enhancement. Although this is very classic, it is not diagnostic, and tissue is necessary to make a pathologic diagnosis and start therapy. In terms of pathology, it's a highly cellular tumor, has many mitosis, it is synaptophysin positive, and this neuronal component. There are 4 classic histologic patterns recognized, and although I put them there on the slide for you, I do not believe you would have to recognize this for a test. There is classic histology, desmoplastic, extremely nodular, and then anaplastic and large cell. We also have learned a great deal over the last couple decades about the molecular biology of medulloblastoma, and now there are 4 major molecular subgroups that are accepted worldwide. These are the wingless pathway, or the Wnt subgroup, the sonic hedgehog pathway, or the group 3, and the group 4 group. And there is a little chart on the right depicting the different ages of the patients, the common molecular aberrations, and other findings in these patients within these subgroups. Now, treatment paradigms are evolving based on these, and they really not have become standard of care. We do know that the Wnt pathway tumors have the best prognosis when we look at retrospective historic subsets of patients. This is now being tested prospectively in an ongoing COG trial, ACNS 1422, but this has not become the standard of care. In this trial, we are trying to reduce therapy in these patients. Here is another way of looking at it. I wasn't sure if some people prefer tabular formation rather than a pictorial representation as on the previous slide. So this may be helpful for you. Again, I think the 2 things I would really highlight to remember is that the Wnt pathway have excellent survivals based on historic data, and the group 3 tumors seem to have the worst prognosis. There is a classic risk categorization. This is not based on molecular findings. This is a standard risk and high risk, and it is based on some features that are part of the patient and the patient's tumor. So the patient's age greater than 3, if you have a gross total resection, no signs of metastasis, and no anaplastic histology, you would be considered standard risk. And then if you have any of those negative features, a large residual tumor greater than 1.5 centimeters cubed, if you have metastatic disease, either by lumbar puncture or by spine MRI, or if you have diffusely anaplastic histology, those are considered high risk. And then we do separate out the infants, usually patients less than 3, although internationally that varies, can be less than 4, less than 5. But those patients are treated and kind of categorized differently. In general, the standard risk patients are treated with craniospinal radiation at slightly lower doses, and then maintenance chemotherapy that usually lasts about 15 months. High-risk patients also get craniospinal radiation, usually at higher doses, full dosing at 3,600 with boost to their tumor, followed by maintenance chemotherapy that is typically a shorter duration, but more intense, usually over 6 to 9 months. And then the infants, I think this is a very testable point, are typically treated with high-dose chemotherapy and autologous stem cell rescue, plus or minus radiotherapy. These patients, this is an effective strategy for them when they have medulloblastoma. And this is a manner of the boards testing both a BMT question and also a brain tumor question. So I would consider this an easily testable point to remember. Okay, I also gave you a tabular formation of the historic risk stratification if that's easier for you. And then the outcomes for medulloblastoma, this really varies depending on age, risk category, and molecular subtype, although as I mentioned, this is evolving and mostly based on retrospective series. Standard risk patients, based on the classic definitions, typically have a 5-year overall survival of about 75 to 90%. High-risk patients have a 5-year overall survival about 40 to 60%, and then the infant group ranges to about 50 to 70%. Remember, the Wnt patients do very, very well and have excellent survival. I think that could be one thing that they would test you on. Okay, we're going to move on to our next tumor, which is ependymoma. So ependymoma is the 3rd most common pediatric brain tumor. It is a glial tumor with ependymal cell differentiation. The ependymal cells line the ventricles of the brain. So oftentimes these tumors occur within a ventricular surface or outpocketing into the ventricle, although they technically can occur anywhere in the brain. And they're most commonly seen in the posterior fossa or the cerebellum, like many of the pediatric brain tumors that we've talked about. But they can also be seen in the lateral ventricles and the spinal cord, for example. If we come back to our infamous pie chart, the ependymomas are the third most common tumor that we're going to be talking about, and they represent about 8 to 10% of all the pediatric brain tumors that we see in our population. There is an increased risk in patients with neurofibromatosis type 2, different than type 1, with the patients that get low-grade gliomas that we discussed previously. Patients with NF2 also have a risk of acoustic schwannomas. That typically occurs later in life, but we do often see patients in their teenage years that can develop those as well. But that would be a genetic association with ependymoma, which is NF2. In terms of diagnosis and evaluation, you must have tissue for diagnosis. So you cannot base it on imaging alone, like most of the tumors that we've discussed, with the exception of DIPG. The goal is, again, gross total resection, as this has been prognostic, in many historic series. The risk of spine metastasis is pretty low, about 10 to 15% of patients, but it is standard to get both a lumbar CSF cytology and a full spine MRI on these patients, just like medulloblastoma. And the timing of these is exactly what I described for the medulloblastoma patients. So you can see it written here again, but it's exactly what we discussed previously for medulloblastoma. Here is a classic image of a patient with an ependymoma. They typically have a heterogeneous mass, again, most commonly in the posterior fossa. So you can see here on an axial and a sagittal view, a mass in that fourth ventricle area. They often have heterogeneous enhancement. They can sometimes have calcifications as well. But again, although this is classic, it is not diagnostic, and you do need tissue to make a diagnosis of ependymoma. Pathology, I really don't think that they would test you on the pathology of ependymoma, but there is one classic finding that is pretty indicative of ependymoma, so I have included it here, and I did highlight it in red. It is something called a perivascular pseudorosette, and you can see it in this picture. It's called a pseudorosette because it is surrounding a vessel and not a vacuole. And that's why it's called perivascular. And so you can see appearance of it right here. This is pretty indicative of an ependymoma. Again, I would be surprised if they tested you on that. And then the molecular biology of ependymoma is evolving as well. Similar to ependymoma, we have learned that there are numerous subgroups, but this has really not universally impacted how we treat patients, although we are starting to utilize it more to tailor treatments in future clinical trials. But for standard of care, I doubt that they would test you on this. I think the one thing that could maybe come up is that patients that have ependymoma with a real effusion have a very poor prognosis. So that might be something that you want to keep in mind. In terms of treatment, a maximal surgical resection is ideal. This has consistently been found to be important for a good prognosis in patients, with historic studies showing this numerous times. Localized tumors are typically treated with a resection followed by focal radiotherapy, not craniospinal radiotherapy, like the medulloblastoma patients. So that's a distinction. So even though medulloblastoma patients may have localized disease, they get craniospinal radiation, but that's different than ependymoma patients that typically will get focal radiotherapy, unless they have metastatic disease, in which case they may get craniospinal radiotherapy. The role of chemotherapy really remains unclear for ependymoma. Historically, it has not seemingly been effective. The most recent COG trial just presented and not even published show that there may be some distinct areas where chemotherapy is effective in ependymoma. However, this just was released at the most recent COG meeting, so I do not think this would be part of your testing at all. And for this test, I would say that chemotherapy is really not an effective strategy, and surgical resection and radiotherapy are the standard of care. And we actually use radiotherapy down to very young patients in this population, especially if they have tumors in their posterior fossa, so down to age 1 in the most recent COG study. In very young patients, younger than this, we can sometimes use chemotherapy alone approaches to delay radiotherapy. But again, that's in very young children, often infants less than 1. And then outcomes. Ependymoma is actually my very least favorite tumor because it's the one pediatric brain tumor where the 5-year survival is not completely indicative of long-term survival into adulthood. So most of the tumors that we've discussed, when we talk about 5-year survival, that means that most patients will live into their adulthood with very few recurrences after 5 years. This is not the case with ependymoma. Many patients will recur after 5 years, 10 years, even 15 years multiple times. And so if you look at survival at 15 and 20 years, it's probably closer to 30 to 40% long-term survival. And so many of these patients, although we can keep alive with multiple therapies, will eventually succumb to their disease. Also, many patients will have multiple recurrences and have multiple morbidities. So for that reason, again, it's one of my least favorite tumors. Okay, we're going to move on to a rare bird, but something near and dear to my heart, because one of my research interests, along with low-grade glioma, is central nervous system germ cell tumors. So this is a very rare pediatric brain tumor. It has similar histologic features to gonadal germ cell tumors, which I'm sure you're going to hear more about during the talks for the board review. It is a very unique tumor because it can sometimes have circulating tumor markers in the blood and the spinal fluid, which help make the diagnosis and follow and monitor treatment response. So these are AFP and then beta HCG, as you are well aware. In CNS germ cell tumors, there are 2 major categories recognized. This is a little controversial internationally, but for this test and in the US, we recognize what is called a germinoma, otherwise known as a non-secreting tumor, which typically have a better outcome, and then a non-germinomatous germ cell tumor, or an NGGCT, otherwise known as a secreting tumor, which typically have a worse outcome. Here's our pie chart that we've been discussing throughout the talk. And as you can see, in the United States and most North American countries, the incidence is very low. We have about 2 to 3% of all pediatric brain tumors represented by CNS germ cell tumors. Something unique that you could maybe be tested on is that this is different than Asian countries, particularly Japan, where there is about 10 to 15% of all pediatric brain tumors that are germ cell tumors. We don't understand the reason behind this, but our Japanese colleagues are world experts on this diagnosis because they see many more patients than the rest of us. There is not really a defined known risk factor for CNS germ cell tumors. There is some literature about Down syndrome and some association, but that will not be tested because those are a few case reports and nothing well defined. In terms of CNS germ cell tumor imaging, the most important take-home point is that these would be heterogeneous and enhancing masses in one of the 2 most common areas. So you would see a mass either in the suprasellar region, also known as the pituitary region, or the pineal region. And sometimes actually you can see what's called a doublet lesion or a bifocal lesion in about maybe 10% of patients. And that's what's represented on the chart right here, picture right here, where you can see a patient with bifocal lesions. This actually is treated not as metastatic disease, but as 2 main primaries and treated almost as a focal disease. Also, I wanted to highlight some of the symptoms you can see in the most common locations because they're a little unique. So for patients who have tumors in the suprasellar or pituitary region, they can develop endocrine symptoms like diabetes insipidus. This can actually be one of the first symptoms that you see for a prolonged period of time before they get hydrocephalus and the classic symptoms of vomiting and headache. They can develop panhypopituitarism, and they can develop ocular dysfunction or vision abnormalities. And then in the pineal region, you can see Pernaud's syndrome, which I have defined for you below, or increased ICP with vomiting and headache. Those are a little bit unique, but those are findings that you can see in these patients, so I would keep in mind. Many of the tumors that we see in CNS germ cell tumors are mixed tumors, so they see a combination of germinoma and non-germinoma germ cell tumor, but you can see pure germinoma, which are treated in one way, and then mixed tumors, which would typically fall in the non-germinomatous germ cell tumor category and are treated in a different way. Among the NGGCT group, there are specific histologic variants. So endodermal sinus tumor, yolk sac tumor, and embryonal carcinoma, and actually teratoma falls in that group as well. We diagnose these patients and evaluate them in a very specific way. So serum and CSF tumor markers should be drawn in every patient at the time of diagnosis. And if the tumor markers in the serum and CSF are very elevated and you have a tumor in one of those locations we've discussed, it can be diagnostic as an NGGCT without tissue. Now, this is controversial of what the cutoff is. So I think if they gave you a question on this, you would have a patient who has a suprasellar mass or pineal mass with an AFP or beta HCG in the thousands. Because if they gave you a low level, it would not be fair because we don't agree about that in the community at large. If it's a germinoma, the classic teaching is that the tumor markers are not elevated. Again, this is controversial because some germinomas have low levels of beta HCG, but I think if they were testing on this, they would give you a tumor without much elevation. And then if the markers are not diagnostic, a biopsy is necessary to get tissue and make a diagnosis. Again, similar to medulloblastoma and ependymoma, you need a lumbar CSF for cytology and a spine MRI for staging. In terms of treatment, germinoma is treated with neoadjuvant chemotherapy, typically carboplatin and etoposide, and followed by radiotherapy, which is usually focal and includes the ventricular surfaces as well, the whole ventricle, because that's where tumors recur if it is only treated with focal radiotherapy. You can also treat with radiation alone, although this practice is no longer used universally, but it is an effective strategy. And then non-germinoma germ cell tumors are also treated with neoadjuvant chemotherapy followed by radiation therapy. The extent and dose of radiation is very controversial. You can use craniospinal or focal and whole ventricular. I don't think they would test you on that. Both of them is important to do a second look surgery after chemotherapy if there's residual mass, because there is an entity called growing teratoma syndrome in which the malignant component shrinks away from chemotherapy, but the teratoma component grows. And really the only way to get rid of the teratoma component is surgery because it's not very effectively treated with chemotherapy or radiotherapy. Outcomes are very good for germinoma, usually greater than 90% at 5 years. And then for non-germinomatous germ cell tumor, patients with the combination of therapies in the modern era actually are doing quite well as well, getting survivals up to 80 to 90%. There is a subgroup of patients who don't seem to respond very well to chemotherapy. They have less than partial responses, and these patients typically have a worse outcome. But we have not been able to identify these patients up front based on molecular biology. So unfortunately, they're treated the same, and we discover that they're poor responders as we move through therapy. Okay, we're going to go through the last few tumors, the rare tumors, which I have isolated as ATRT, choroid plexus tumors, and craniopharyngioma. We have a slide each on one of these tumors, and then we're getting towards the home stretch, so hold on. Okay, so ATRT, or atypical rhabdoid tumor, is a rare embryonal tumor, embryonal-like medulloblastoma, typically seen in very young children and infants, and it represents about 2% of all pediatric brain tumors. These probably historically were misdiagnosed as medulloblastoma until we understood more about the biology. They do require a full metastatic workup like medulloblastoma, a spine MRI, and lumbar CSF cytology. And historically, they had very poor prognosis, 20 to 30% survival. But with modern therapy, including autologous stem cell rescue and high-dose chemo, and actually sarcoma-like therapy with or without radiation therapy, patients' survival has improved closer to 50%. These pathologically are identified by the loss of INI1 on immunohistochemistry or on detailed molecular testing, and this is easily testable. There is something called rhabdoid tumor predisposition syndrome, a germline mutation in the SMARCB1 or SMARCB4, and it is associated with an increased risk of ATRT or other familial tumors like rhabdoid tumors of the kidney and schwannomatosis. Again, I think that's something you could be tested on. Choroid plexus tumors, another rare tumor, represents about 1 to 2% of all the brain tumors we see in children, most commonly located in the lateral ventricles and often present with obstructive hydrocephalus. There are 3 flavors. There is choroid plexus papilloma, atypical choroid plexus papilloma, and choroid plexus carcinoma. These usually present in very young children, as I said, with increased intracranial pressure. A goal of a gross total resection is often curative in patients with choroid plexus papilloma, but Carcinomas are much more aggressive and typically require chemotherapy and radiotherapy, and they have a much worse outcome, oftentimes 20 to 50% survival at 5 years. Also, the carcinomas can be associated with Li-Fraumeni and TP53 germline mutations. Again, an easily testable point to keep in mind. And our last specific tumor is craniopharyngioma. This is a rare epithelial tumor thought to be due to maldevelopment origin. It represents about 6 to 9% of all pediatric brain tumors. It often presents in the suprasellar and pituitary region and leads to headaches, vomiting, visual field cuts, and endocrinopathies. It often shows a mixed and solid mass appearance on MRI, and when you take a biopsy, you will often see squamous epithelium lining a cystic cavity with calcium and keratin. Ideally, a gross total resection could be curative in those patients in which the tumor recurs, or you cannot get a gross total resection. Adjuvant radiotherapy is an effective treatment modality as well. And although if you look at progression-free and overall survival, they're quite good, many of these patients have significant morbidities affecting their quality of life. They have long-term endocrinopathies, hypothalamic obesity. They can have behavioral changes, frontal inhibition, disinhibition, visual dysfunction, and seizures. So if I get out of my soapbox for just one moment, this is the reason I hate the term benign. This is a benign brain tumor, which causes significant problems for patients. But again, the board is not worried about my soapbox. They're worried about testing you. So for the purposes of the board, this would be considered a benign low-grade tumor. Okay, a couple more slides and we'll be done. We'll talk briefly about late effects. So in terms of late effects in brain tumors, after CNS radiation, we've talked about this briefly, there's an increased risk of a secondary malignant brain tumor, most commonly a high-grade glioma or a meningioma. We talked about the example of patients who historically got CNS radiation for leukemia, but actually it could be the case for a patient, for example, who had medulloblastoma, got craniospinal radiation, and then 7 to 10 years later could develop a high-grade glioma. It's very frustrating and devastating because you've cured them of their medulloblastoma and they develop a new brain tumor. Oftentimes, the latency period is about 7 to 10 years, and the risk is about 5% or less. But again, if you get it, it's 100%, and so it can be a devastating finding. On the right side on that table, you can see some of the other common radiation-induced late effects: ototoxicity for our patient and the young children, neurocognitive decline, a major reason we avoid it in very young children. You can see endocrine dysfunction, the secondary malignancies that we already talked about, and then cerebrovascular events like strokes or moya can develop later on. And then the common chemotherapies that we use in brain tumors are listed there. I'm sure you'll hear more about these in other talks, but I listed some of the common late effects that we see: cyclophosphamide infertility, for example, cisplatin ototoxicity or renal toxicity, etoposide secondary leukemias, intrathecal methotrexate. You can sometimes see leukoencephalopathy on imaging, which may or may not be symptomatic. And then doxorubicin, which we typically only use with ATRT when we use those sarcoma-like therapies, but as you know, can lead to cardiac dysfunction. So here, I would remember these because it's a way of incorporating both the brain tumor and late effects section and are easily testable questions. Here is a classic question I put on here. I kind of alluded to this already. A 20-year-old male comes to the ER with complaints of headache and vomiting and right-sided weakness. He was treated for medulloblastoma at age 10 with craniospinal radiation and chemotherapy. And then when you do imaging, you see a left-sided mass with associated hydrocephalus and a midline shift. You have to think that this could be a radiation-induced secondary malignancy. A recurrence that far away of medulloblastoma would be very, very rare. And so it's likely a high-grade glioma or a meningioma, remembering that the latency period is often 7 to 10 years, or sometimes even longer. And believe it or not, that ends our whirlwind tour through brain tumors. If you have any questions at all, I think there's a live session at the actual course that we're going to do after my talk right now. But if you have any questions, please feel free to email me. There's my email there about my talk, about boards questions that come up when you're studying, or even about patients or clinical care. I wish you the very best of luck. You will get through this. And please email me with any questions. Thank you so much.
Thank you for participating today in our session, and thank you also to Dr. Fangacero for speaking. We will now open up our Q&A and just be able to address. There's 2 open questions, and then we can review some of the answered questions to ensure if anyone else has follow-up questions from those.
Great. Yeah, I can do the open ones first. Hi, everyone. Good morning. The first question from Harry is there a predilection for the location of secondary CNS tumors? And actually, the predilection is more based on the overlapping of the radiation typically, so it can vary. So I don't think this is something you would be tested on, but since you get craniospinal radiation for patients with medulloblastoma, for example, pretty much the risk is anywhere in the brain and spine. So I don't think they would test you in a specific location. The next question is from Shira. For low-grade gliomas, you don't need a biopsy, but high-grade you do before gross total resection. Can you reinforce how you might tell the difference on imaging? So actually, for both, most times the imaging is reviewed and a gross total resection is tried to achieve regardless, not knowing what the pathology is beforehand. So we look at the imaging, and for almost all brain tumors, with rare exception, you're going to try to get a gross total resection. So we don't typically do a biopsy before and then move on to a surgery unless we're really confused. So in general, you're going to try to get it all out right away and then know the histology afterwards. The next question from Amir is, for low-grade gliomas that have a partial resection, do you always treat with chemo or do you consider a wait and watch approach? That's a great question. This kind of varies. I don't think that they would get into the intricacies of this on the board exam, but you're absolutely right. In clinical practice, if it's a small residual lesion after a partial resection and the patient is not symptomatic, some practitioners will monitor the patient with imaging every 3 months, and you don't necessarily have to dive into therapy. But this is not standardized internationally or nationally. I think it's more practitioner dependent. The next question from Catherine is, are there clinical or imaging findings associated with secondary meningioma that distinguish it from high-grade glioma that we should know? So the first part is yes, a meningioma does have a classic appearance on imaging, but I don't think you would need to know that for this exam. I doubt that they would do that, but neuroradiologists can give you a clue when looking at a meningioma based on its pattern on MRI that it may be a meningioma rather than a high-grade glioma. Usually you would want to take a meningioma out as well, so you would find out the pathology. It's not diagnostic on imaging, but it can give you a clue based on some of the characteristics. I think those are all the open questions. Would it be helpful to go over some of the ones that are already answered, or since I wrote answers, we should just wait for more live questions? What's best? Kathleen?
Well, there's a few more lives that have shown up. And one of them is for CNS testing for the exam. Do you typically wait 14 days post-op, or can you get it pre-op with no concern for the safety?
For NF1 patients, oh, I see. Okay, there's a couple. I'm sorry, I wasn't scrolling far enough down. So I can do Harry's first. For NF1 patients with astrocytoma, does the principle of management similar to OPG? It is. The OPGs in patients with non-NF1 typically seem to be a little more aggressive. The only distinguishing feature I would say is that patients with NF1 often have a more indolent course. And so if they're not having visual dysfunction or they're not having a neurologic deficit, we may not treat those patients. Whereas OPGs in non-NF1 patients, practitioners are more apt to treat because those will be more aggressive and typically grow. For CNS testing for the exam, is it always wait 14 days post-op, or can you get pre-op if no concern for safety of LP? I would say I would answer 10 to 14 days post-op. Most of the time, people just won't do an LP. We sometimes do the spine MRI before a surgery, but the LP, just because of that risk, even if it looks low on imaging, is not typically coordinated before. So for purposes of the test, I would always say that a lumbar puncture for staging for medullary and ependymoma and germ cell tumors should be done 10 to 14 days post-operatively. What is the lowest stage you've used selumetinib? Do you ever use it in kids less than 2? I don't think this will be on the boards, but if we have time, it would be great if you can give your thoughts. Yeah, so you're right. So selumetinib does not come in a liquid formula currently. So patients have to be able to swallow tablets. And so currently most young infants don't fall into that category. I have seen a few 2-year-olds being able to use it, but hopefully we'll get safety data. There is supposedly a child-friendly formula coming in the next 6 to 12 months that will test. But there are other MEK inhibitors that do have child-friendly formulas that you could utilize if you've exhausted other things. So for example, trametinib. Can you differentiate brain necrosis from secondary tumor, Raj? So on imaging, you can sometimes distinguish what looks more like radiation necrosis versus a secondary lesion. In high-grade glioma, it gets very sticky, especially right after radiation therapy, although usually a secondary malignancy will happen many years after radiation therapy. You can also use advanced imaging, which I don't think they would test you on the boards, and look at things like perfusion and see if there's perfusion to the area, it's more likely tumor, versus if there's lack of perfusion to the area, it could most likely be necrosis or breakdown of tissue. Again, I don't think they would test you on that on the boards at all. Sorry, just another one. As I understand, we wouldn't biopsy NF1 optic pathway gliomas. Do we need a biopsy for non-NF1 OPG? Again, I don't think they would test you on this. Most practitioners, I think, would argue that you should get a biopsy of a non-NF1 OPG, because rarely it can be a different histology. And for molecular testing features for therapy down the road, most people would argue to try to do a biopsy if feasible. Do OPGs in NF1 stop growing eventually, or do they continue to grow or have a risk of malignant transformation throughout the patient's lifetime? So throughout childhood, they can have growth of their tumor. Actually, this is something I didn't talk about, but low-grade gliomas in general, when we look at large retrospective historic studies, it appears that as you get into young adulthood, these tumors kind of seem to peter out and do not cause more problems. That's same with most patients with NF as well. There does not seem to be, in patients who develop a low-grade glioma who have NF1 as children, a risk of malignant transformation. This is distinct, however, that patients with NF1 who develop low-grade gliomas in adulthood, those oftentimes do behave more aggressively and can transform. But for our testing, for PEDS boards, I would say the answer to your question is that there's not a higher risk, and that most of these patients will not have problems with more aggressive tumor later in life. At what point would you be able to start chemoradiotherapy post-op once diagnosis is confirmed? Daisy, I assume you might be asking about like medulloblastoma or ependymoma. If that's the case, usually we wait for all of the information to be back. So usually within the first month post-surgery, and that'll give us time to do the post-operative MRI, the lumbar puncture, and have your histology or pathology confirmed. Also in this era, although you won't be tested on it, most people will often wait for the molecular testing to help guide them and see if they're eligible, for example, for the COG study, which does its own molecular testing. But most of the brain tumors in general, we try to treat within the first 4 weeks post-surgery. This can vary a little bit on studies. For example, some of the ependymoma studies give you a little bit more leeway than 4 weeks. But in general, within 4 weeks, you want to start. With some of the high-grade gliomas like DIPG and GBM, sometimes practitioners try to start a little sooner than that to get things going. So within 2 to 3 weeks postoperatively, they try to get radiation therapy started. Let's see. Is there another one? I'm looking.
Yes, from Hannah.
Yes, from Hannah. Is H3K27M found in brain tumors aside from DIPG? It's a great question. Yes, there's actually an entity identified by and accepted by the World Health Organization called diffuse midline glioma H3K27 mutant. So the DIPGs for sure, but there are other midline locations. So you can have a midline high-grade glioma in the thalamus, for example, the spinal cord, and even the cerebellum in the midline, and they can have H3K27M positivity. And seemingly based on the data that we have available, just having that H3K27M, if it's a high-grade lesion in the midline, makes it have an even worse prognosis than other high grades, which already have a poor prognosis, which we discussed. For the boards with low-grade glioma with subtotal resection with BRAF mutation, is treatment answer chemo with carbo? Oh, sorry. This keeps with carbovincristine in real life, what is your practice? Okay, so I would say, yeah, for the boards right now, I would not use a molecularly targeted therapy as first line, because as you know, that's being tested in the upfront COG study right now. So I would say if it's subtotally resected and needs to be treated, you would go to chemo first with like carboplatin, vincristine, or vinblastine monotherapy. My own practice is, yes, as much as, even though it's my own research and I believe it's going to be effective, I try to enroll these patients on clinical trials when testing new agents. And if they can't enroll or are not eligible, I usually actually use the standard of care carbo or vinblastine because I don't like to use things off study, but I'm a little more conservative that way. Some people are using these agents off study based on the phase 2 data. Are there any specifics on timeframes of observation surveillance period after treatment? Every 3-6 months, then yearly, for how long that would be important for boards? I don't think they would ask you this, but I would say in general, for almost all pediatric brain tumors, while you are on therapy and the first year after a surgery, even if you're being monitored, most practitioners will do an MRI every 3 months, and then that spaces out based on whether you're still on therapy or not. But while you're on therapy, most practitioners, regardless of the histology, will get imaging almost every 3 months. Will the board still refer to DIPG as DIPG despite the changing terminology? I would say they will still probably use the term diffuse intrinsic pontine glioma because we still use that in the community in addition to the diffuse midline gliomas H3K27 mutation. Do you recommend any monitoring for those with predisposition syndromes? I have to tell you that that's not my area of expertise, but I definitely do recommend that these patients see genetics and genetic counselors and then follow the paradigms recommended by the genetics teams. But many of these patients will require specific routine evaluation and monitoring and imaging. For example, even the NF1 patients with that diagnosis are often monitored for their vision and monitored for the development of neurofibromas, for example. You mentioned treating bifocal germ cell tumors like 2 primaries rather than METs. Can you elaborate? So basically, they would not get, in general, if it's a germinoma, not get craniospinal radiotherapy. They would still get the same chemotherapy if they had a bifocal germinoma, and then they would probably get radiotherapy to the whole ventricular area and then boost to both the pineal and the suprasellar region. But they don't get the craniospinal radiation that a patient with metastatic disease to the spine, for example, would get. For patients who have localized intracranial ependymoma, how long often do you follow spinal imaging? This is controversial and everyone does it a little different. I don't think they would test you on this on the boards. I would say that most people do it at baseline and then at least once a year during surveillance. Also, once a patient recurs, which unfortunately most of these patients do recur, at the time of a new recurrence, most practitioners will do a repeat spine MRI to reevaluate and stage and make sure there's no new metastatic disease. How long patients with SEGA need to continue on mTOR inhibitors? I see the questions are getting more difficult. This is an answer that I don't think we have in the medical literature yet. Many of these patients are on for years and years. There does not seem to be a final answer on how long they should be on. So I do not think the boards would test you on this. There are other people who are a little more experienced in treating patients with NF2 and mTOR inhibitors, but many patients are on over 1 and 2 years if they are tolerating it without toxicity. For choroid plexus tumors, do we need to do full staging with spine MRI and CSF? If they have a choroid plexus carcinoma, yes. If it's a papilloma, no. And if it's an atypical, most people would do full staging just to be safe. But the papilloma, which is the lower grade, that is usually cured by surgery, most practitioners would not do a full staging workup for. Is there any predilection for the location of secondary CNS tumors? I think we answered that one. It's really based on radiation dosing more than anything. So I don't think they would test you on that. And if you got craniospinal radiation, there's a risk anywhere in the brain and spine. Do you expect any board testing points on CNS embryonal tumors, former PNET? I don't expect they would test you on that because the new World Health Organization has just started classifying this into distinct entities. And as you say, PNET is no longer in favor. I think they'll focus more on medulloblastoma and not embryonal tumors or enantiors, for example. Do we need to know the specific chemotherapy aside from vincristine for medullo? Are there a standard induction maintenance regimen that we should know for boards? I would be surprised if they test you on this, but you're right. During radiation therapy, patients get weekly vincristine, typically standard. And then the regimens that they get for maintenance can be CCNU, cisplatin, and Cytoxan with vincristine, and it alternates. And then for the high-risk patients, they oftentimes will get cisplatin and vincristine, and they can get alternative therapies as well. I don't think they would test you on that. I may be missing some of these. They're coming pretty quick. So if I miss some, feel free to email me. And I know Kathleen may have to cut me off soon. For metastatic germinoma, is chemotherapy indicated? Yes, if you have metastatic germinoma, most practitioners would treat with the same chemotherapy regimen first, but your radiation field and volume would change. So if it's metastatic, you oftentimes would do craniospinal radiation. Will the boards make any distinction between protons and photons? I would say they will not because the data is not perfect yet, and both are effective strategies. Can you comment on cerebellar mutism as a complication? Yes, so patients who have a resection of a tumor in the posterior fossa can often, probably 20 to 30% of patients when looked at accurately can develop something called cerebellar mutism or posterior fossa mutism, in which they have difficulty with speech, they can have visual eye dysfunction, and they can have behavioral issues. Many times this gets better with time. There's not a specific therapy to treat it other than rehabilitation. There are some experimental therapies utilized. I think I would just know that this is a possible complication post-surgery after a posterior fossa resection.
All right, so that is all the time we have. Thank you for attending this session. The chat has now ended and no future questions will be answered. Please watch for further details regarding the virtual office hours in late February and March for an additional opportunity to ask questions and interact with the speaker. Also, don't forget to watch the Launch Networking Chat button in the top right corner to set up your chat profile and connect with peers during the breaks. And don't forget to join us for the virtual networking and social today at 3:30 p.m. Central Time for an opportunity to network with our pediatric hematology oncology leaders and mentors and a chance to win an Amazon gift card. The next session is acute lymphoblastic leukemia, which will begin at 11:15 Central Time. Please exit this room and join the sessions room at the appropriate time. Enjoy the rest of your course.